So I'd like to introduce Chris Longhurst more formally, and really thankful that he was able to and willing to make this trip to visit with us. And we'd also like to thank Royal Children's Hospital and the Center for Health Analytics, who's co-sponsoring him. And he'll be here for another week with us, working on how to really help us think through some of the challenges and collaborative opportunities that we have. Chris is the thought leader in the field of digital health. He's currently the Chief Medical Officer and the Chief Digital Officer at the University of California, San Diego Health. And this dual complementary role that he plays provides leadership to medical staff, ensuring that standards and protocols are in place to provide the highest quality of care to patients. He also serves as Associate Dean at the School of Medicine, overseeing and aligning education and research missions within the clinical environment, and leading the journey to become a highly reliable learning healthcare system. Chris is passionate about implementing innovative digital solutions that help improve the patient experience. He leads a new center in health innovation, and we are really gonna learn from him. And we've kind of primed him with a question of, how do you bring the research mindset and that learning mindset together with the healthcare providers and environment to make innovation happen? How do you make it happen? So he's going to share some experiences with us. Thank you, Chris.
Well, thank you for the generous introduction. It's really wonderful to be back in Melbourne and enjoying the conversation and the weather. I want to thank Dr. Chapman for hosting, Dr. Chung for the advisory panel chair role, Dr. Gunn for helping kick us off yesterday. What I wanted to share a little bit today was about our journey across the University of California and at UC San Diego Health towards becoming a learning health system. And as I think Dr. Chun mentioned, we're going to start with a story, right? Because stories are powerful. And this is a story actually not from when I was in San Diego, but when I was at Stanford, where I spent 15 years on faculty. I'm a pediatrician, and this is about a young adolescent girl. I know we've got some clinicians in the audience, so what does this patient have? Lupus, yeah. This wasn't actually the patient, by the way. This is from Google Images. But it gives you a sense of the patient that was admitted to our hospital in the middle of the night. I was on call. She was flown in by life flight from an outlying hospital because she was in multi-organ failure. She was very, very sick. And I was at her bedside in the intensive care unit with one of our pediatric rheumatologists who I happened to have trained with. And Jenny asked a really, really important question. She said, hey, this girl's got nephrotic syndrome. She's losing protein in your urine. She's probably hypercoagulable. Should we anticoagulate her? Now, you guys in adult medicine anticoagulate everybody who's not bleeding, right? In pediatrics, we don't do that. And so this was sort of an unknown question for us. So the first thing we did at her bedside was we looked it up in Medline. And what was the answer in PubMed? How many studies have been published about teenagers with lupus in organ crisis and clotting risk? 0, right? So no level A evidence available. So then we did the next thing any good evidence-based clinician would do. We looked for the level B evidence. So we called our experts. And the first pediatric nephrologist we called said, I would absolutely anticoagulate her. I had a case about 6 months ago, yada, yada. What did the second one say? Absolutely not. I had this case about 6 months ago with sequelae from anticoagulation, right? So we were left there holding the bag, but that's when Jenny did something that hadn't been done before, at least published, which was we had access to a data warehouse. And on the day that this girl was admitted, we actually did a search in that warehouse for similar patients. And we identified similar patients by admission to the ICU with a diagnosis of lupus. And then we looked for similar and different lab findings. Were they in multi-organ crisis, they have pancreatitis, et cetera. Then we looked for the outcome of clotting, which of course required looking through the free text, right? And so just was described earlier this morning, we were able to kind of search across this cohort of patients very rapidly for thrombus, thrombosis, et cetera. And what we found, as you can see on the right-hand side there, was an odds ratio of 8 to 15-fold higher for children like her to clot. And based off of that, we made the decision to anticoagulate her. Must be that time. So was it the right decision? Well, the answer is we don't actually know. What we knew is that this girl didn't clot, and she didn't have any sequelae from the anticoagulation. But this was an N of 1, it wasn't a randomized trial. What we do know is that we made the best, most data-driven decision that we could in the absence of good peer-reviewed evidence. And if this were my daughter, my family member in the hospital, isn't that what you would want, right? And so this article describing this situation was actually cited in the very first report by the Institute of Medicine in the United States about a learning healthcare system. And it described this concept of getting real-time insights from clinical data or real-world evidence, right? Our health system does not learn from patients on a regular basis. Now, there's exceptions. As a pediatrician, I'm a little bit biased, but pediatric oncology is an area where almost every child with cancer, which in the United States is about 5,000 new diagnoses a year, is on trial. Pragmatic trials, rapid learning, without new monoclonals and biologics. Advancements in childhood leukemia have been very successful the last 20 to 30 years, right? But what percentage of adults with cancer are on clinical trial? In the United States, it's 3%. So maybe it's 8% here. But that still means that 92% of our family and friends with cancer are not contributing to better outcomes for cancer, right? And that's what this is about. How do we learn from every patient so that we're delivering better care all the time? Now, Jen, this one's for you because there is a really important patient standpoint on this, right? If you're using data for ongoing quality improvement, shouldn't patients be a part of this? In fact, the Hastings report, which is a big ethics journal, released this article I think was critically important at the same time as the Institute of Medicine report. And their conclusion was that just as health professionals and organizations have an obligation to learn, patients have an obligation to contribute to, participate in, and otherwise facilitate learning. It's a little bit of a paradigm shift because for so many years, right, the pendulum swung very far in terms of clinical trials, consent-based studies, and not using patient data for learning purposes without consent. And yet we now have digital tools that allow us to do exactly that, to consent patients to participate in learning across the health system. I also want to mention that I hold no stock in this company, unfortunately, but my colleagues at Stanford who continued to do some great work after I left have actually commercialized this. So there's a company called Atropo Health that has actually taken this concept. Dr. Nigam Shah, who is a faculty member there, was the co-founder along with our chair of medicine. Bob Harrington is a cardiologist and clinical trialist. But the reason I share this is because this is really important. If we want our digital therapeutics to have an impact beyond our own health system, commercialization is the best way to do that. Make it sustainable, right? Bronwyn will help you with that. She'll fund you. Right, Bronwyn? So commercialization is an endpoint. It's not something that we should be ashamed of. It's an opportunity to take things that work beyond our own health systems. Now, shifting gears a little bit, that was a story about how electronic health record helped, but it doesn't always help, does it? In fact, as my colleague, Dr. Abraham Verghese, author of Cutting for Stone, said, the EHR is only part of the issue, right? Other factors include rapid patient turnover, decreased autonomy, merging hospital systems, aging population. But even if the EHR is not the cause of burnout, it most certainly has become a symbol. And that may be a little bit less true here than it is in the United States, where our physicians measure pajama time, right? How long they're documenting at home at night after clinic. But this is a big problem. And so I was really inspired the last time I came to Melbourne. Anyone from RCH here? Couple of pediatric visitors. So here I am with Dr. South at RCH again, and was rounding in the ICU. We're getting ready for the RMH kind of implementation. And I noticed that the critical care notes were not only shorter, but actually way more valuable. They weren't full of copy and pasted information. In the United States, we write our notes for compliance, regulatory, medical legal purposes, for CYA, and they're crap, right? And so I actually came back to the States and asked our EHR vendor, could I take a look in a de-identified way at note length across all your clients? And here's what we found. So in the dark green are the international clients, and in the light green are the US clients, right? And you can see the median note length is about 4,000 characters, right? US physicians are writing novels, or at least copying and pasting these novels, right? It's a big problem. In fact, the shortest US notes were longer than the longest international notes. I will say RCH is up there, RMH is not, because you guys weren't live yet at that time. But it shows that there's a fundamental difference in how the EHR is being used. Same technology used very differently. And so this actually was cited by CMS in a large initiative across the United States called Patients Over Paperwork, with some regulatory changes to decrease requirements around notes for billing purposes. And we're still making progress there because it's been baked into sort of habitual methods. You know, you want to bill the most you can. Now, fast forward, I haven't been back in 4 years, of course, because of this little thing called the pandemic. And UC San Diego was actually on the forefront of this. So although it was declared in March internationally, in early February, San Diego was one of 2 sites in the United States where Wuhan patients who were expatriates were evacuated. So we learned yesterday, Peter's a big Top Gun fan. They actually landed at Miramar, which is where Top Gun, the first movie, was filmed. And the county called us and said, listen, if we have any COVID positive patients, actually at the time it wasn't called COVID, remember? They said, if you have any COVID patients, is UC San Diego ready to help? Now, we have a unique relationship with the county. We're a safety net hospital, and so of course our answer was absolutely. And we ended up, as you see here, treating one of the first 5 cases in the United States. We spun up a command center. We had 100 people figuring out policies and processes and order sets, and our pathology team spun up lab results, and we did new interfaces. And I remember thinking, is this another SARS? Is this much ado about nothing? I mean, we must have spent 10,000 man hours in that first week alone, right? Now, of course, it wasn't. And this early experience was serendipitous because by March 11th, when the White House declared the pandemic, March 13th, when the World Health Organization declared the pandemic, we'd already been dealing with it for a month. We'd already hospitalized dozens of patients, actually. And so when Sue Bakken put out a call for papers, I had one of my surgical residents, Dr. Jeff Reeves, write up our experience for the last month to try to help others. And did not realize this would become my most cited paper ever, solely because it was the first, so I guess timing is everything. But in this paper, we described some of the efforts that we were doing very early on, and one of those in particular was analytics. So by the time the pandemic was declared, we had already developed an executive dashboard about COVID patients in our hospital requiring ventilation, the same thing everybody in the world ended up having, right? But this dashboard was ready on March 13th, and I remember I went to my boss, the CEO, and I said, look, this is all de-identified data. Is there any reason why we shouldn't be sharing this with all of our medical staff? Because they want to know what's going on. And she said, no, that sounds good. That's a good idea. Let's do that. And the next day I came back, I said, we're sharing it with all 600, 700 of our faculty physicians. Shouldn't we be sharing it with all of our trainees? And she said, yeah, I guess we can trust them. I came back, I said, our management teams feel left out. Like, shouldn't we share? So sure enough, for about 740 days, this dashboard went out on a daily basis to 20,000 employees across UC San Diego Health Sciences, right? Every single staff member, team member got this. And I'll tell you, I sent a lot of emails to all 20,000 employees, right? Do your cybersecurity training and this and this. This is the only one that never got blowback. In fact, what it got was the most amazing ideas. So here's my CEO being quoted in an article about making this available to all health sciences employees. But Dr. Nancy Binken's pictured here. Nancy was one of our emeritus professors, pediatrician who'd worked at the Center for Disease Control for 20 years. And it turned out, unbeknownst to me, every day when this dashboard came out, Nancy would put the numbers like in an Excel spreadsheet, And then she would calculate vaccine effectiveness, not vaccine efficacy, which is clinical trial-based data, but real-world effectiveness. Because we ran our electronic health record not only for all of our patients, but also for employee health, and also for 40,000 students. And so we knew the vaccination status on this defined population of students and employees. And with that denominator, we could calculate that effectiveness. And Dr. Benkin called me up one day and said, Chris, I'm getting really concerned. You've seen all these infections happening in vaccinated people. This is the Delta wave right there. I said, yeah. And she said, you've heard how the Center for Disease Control said that, you know, most infections are not breakthrough. I said, yeah. She says, well, you can tell on a graph that's just not true. And I said, yeah. She said, in fact, my data suggests the effectiveness has dropped to 40 to 60% when it had been at 95% in our real world data. And I said, well, shit, that doesn't sound good. So Nancy and I and a team of infectious disease physicians submitted this as quickly as we could to the New England Journal. And it was published September 1st. And it ended up getting us a private meeting with Dr. Rochelle Walensky, who was the CDC director. And we explained not only the data to Rochelle, but also our concerns about the need for a booster for our healthcare workers, right? And this was a really momentous Friday evening, I think September 7th, when our data had been presented publicly to the FDA, who approved the vaccine, and then the CDC, who makes the recommendations on utilization. And the CDC Advisory Committee on Immunization Practices made the recommendation that the booster be available to geriatric patients and immunocompromised patients, but not healthcare workers. And my CEO was freaking out, and our teams were freaking out. And later that evening, a bunch of text messages started circulating when Dr. Walensky did something that had never been done before. As the director of the CDC, she overturned the advisory committee recommendations and approved the booster shot for healthcare workers. And so we'd like to think that we had some role to play in that, but that's the type of impact you could have, just a single health system analyzing our data, our real world data in real time, impacting policy across the entire country. Now, another project that I was really proud to be a part of was putting an AI algorithm in production as quickly as we could. So I'll never remember that Friday, March 13th, because the kids, of course, were sent home from school, and I took a meeting that very morning when the World Health Organization had declared the pandemic with our research IT teams and one of our radiologists who did research in artificial intelligence and imaging processing. And Dr. Shao, our radiologist, had been knocking on my door for probably 6 months. Hey, let's put some AI algorithms in production. I was like, yeah, we got a process. You got to go through the committees. Well, that changed on Friday morning, right? So he actually had a paper that had already been accepted, wasn't published yet, based off an open source chest film repository from Wuhan of COVID pneumonia. And he had developed an algorithm that could, with some reliability, discriminate. And so we figured out in 2 weeks how to move that algorithm out of his lab computer and put it in the cloud. And our 25-year-old PAC system would upload every single image as a DICOM image to the cloud where it would get processed, downloaded back into production, so that you can see here you would get these 2 films for every chest film that was taken. And the following Monday, after we put it in production, I ran in the emergency department, and I was asking our ED attending at the time, hey, what do you think? Have you seen these colored x-rays? Like, is it helpful? Now, you have to remember, this is in like April 1st, when, at least in the US, you couldn't get a COVID test unless like the CDC authorized it. I think we had like 5 a day or something. So the ED attending said, yeah, you know, actually, last night we saw a little old lady. She was brought in for possible heart failure. She didn't have respiratory symptoms, but we got a chest film. And there was this color on the x-ray, and I talked to the trainee about it. And even though like she didn't have respiratory symptoms, we decided to get a PCR test. And I was like, well, shit, what did it show? He was like, I don't know, it takes 24 hours to get back. So we stood there looking it up together. And holy cow, it was positive. So you can imagine I followed that patient pretty closely, as did our outpatient COVID team. And she ended up developing symptoms. She was hospitalized, probably more proactively than she would have been otherwise. She never required mechanical ventilation. She was discharged home and did well. And to me, this was a real success story. And I said, well, shouldn't we need to evaluate this, right? We can't just like report an anecdote. And so we got our clinical research team in the emergency department, where it seemed to be having the most impact, to do a study. Now, all chest films across all of UC San Diego were getting processed. And we heard some stories from like our outpatient physicians, but our ICU and hospital medicine physicians are like, no, this isn't changing our treatment, right? But in the ED, it was helping them decide when to order tests, right? When tests were not widely available. And so that's exactly what we found in our study, was that over a course of 5,000 visits and 2,000 chest films, our physicians said 85% that the intervention was easy to use, and 1 in 5 said that it changed their clinical decision making. Now, any of you who've run like clinical decision support teams know that like a 1 in 5 like impact is pretty huge, right? Like we often hope for a 1 in 20. So I thought this was really, really successful. But there was a problem. And this is not in the paper, but if you looked at the data, there was an extinguishing effect over the course of the trial. So this trial occurred over the summer of 2020, right? It was like June, July, and August. We submitted it in September, published in November. And we saw that the responses were actually decreasing over the course of the trial. Why? Because testing was becoming ubiquitous, right? And there was a point that summer where we basically started testing everybody who walked in the ED. And at that point, the AI algorithm was no longer valuable. And in fact, we ended up turning it off at the end of December, which is another good informatics lesson learned, right? You have to constantly evaluate these algorithms, and not just their fairness and ethics, but also their ongoing utilization benefits. Now, it was interesting. I got a Google Scholar alert just last week, and it was about this paper published by a group of Iranian authors in public health preparedness. And it was a really interesting study to me because they looked at 9,123 articles about AI and COVID. And they found 4 where clinical impact was studied. 2 of them were US, 2 of them were outside the US. 1 of the 2 US was ours. Now, on the one hand, I was like kind of proud of that. Like, that's why the Google Scholar alert came up. On the other hand, that's shite, right? An AI algorithm can predict anything you want. But the question is it going to have an impact on patients, right? Predicting outcomes is useless. You have to predict interventions, predict actions that are going to make a difference. So that's why we founded the Center for Health Innovation at UC San Diego Health. So it was founded in the fall of 2021 with some internal seed funding. And just last month, we announced a substantial philanthropic gift to expand and scale this center. But the whole mission and vision of the center is innovation at scale with impact. And actually, the center is owned not by the School of Medicine, but by the health system, because the whole point is to solve health system problems with our patient populations, right? And so we're really excited to partner with our smart researchers in the medical school, in the engineering school, in industry, to solve real-world problems like the AI challenge. So here's a bunch of our AI portfolio right now. I was at a Stanford conference a couple weeks ago, and Nigam, my colleague who founded that company, remember, was sharing that they had developed 2,000 AI algorithms. And somebody asked, well, how many of those are in production at Stanford Hospital? And he said, 2. So we're learning a ton about this now. We're prioritizing them by the ability to have an impact on our patients to improve quality of care. So Peter knows, sometimes you have patients with post-op ileus, and sometimes we refeed those patients too soon. And sometimes those patients get small bowel obstruction. And sometimes those patients with small bowel obstruction get really serious harm and even die in our hospital. And this is a big problem. And no matter how many times we go back to the trainees and the bedside nursing staff and others, we still have SBO as a complication of surgery. And so when we most recently presented our outcomes data at Quality Council, I challenged our surgical quality leader, let's think differently. How can we innovate a solution to this challenge that's not going to be dependent on education? And so we're now partnered with a cloud vendor that will read our notes, integrate data from imaging, and we hope that this will have a significant impact. We have a big problem with boarders in our emergency department, we call them EDIPs, ED inpatients. And so we're doing a bunch of prediction work to better help our staffing. We know when we start this journey on implementing an algorithm, what the possible levers are operationally and who's gonna pull them before we do any coding or implementation. Now, another thing that we found is that EHR data in most cases is necessary but not sufficient. So EHR data may work fine for predicting no-shows in the outpatient setting, although that alone can have some challenges. But Karandeep Singh and others in Michigan have published how poorly it actually does predictions on the inpatient setting. Let me tell you, if you put a sepsis algorithm in that's predicting the likelihood of sepsis based off a clinician ordering a lactate, it's probably too late because the clinician's already thought about sepsis, right? So that just becomes a false alarm. And so our hypothesis, our thesis in the center, is that multimodal-based AI algorithms will have more success in predicting things in a timely enough fashion to be actionable. And so as an example, we're working with Dr. Shamim Namadi, faculty member in biomedical informatics who we recruited from Emory, who does a lot of work around sepsis prediction. And we integrated our bedside monitoring data and imaging data. And what we found is that, at least in situ, his algorithm can predict things much earlier. But the real question is, does it impact patient care? So we're one of the first hospitals we know of to put this type of algorithm in place. It went through an ethics committee. We had to stand up a whole ethics AI committee for all of these efforts. And on the left there, you see our observed to expected sepsis outcome ratio. Now you can see we had a tough year back in 2017, then it was flat for a few years. On the right-hand side, you see pretty significant drops. We're only about 5 months into implementation of the algorithm, so we don't have statistically significant data to share. We certainly are rigorously evaluating this, but the trends and the anecdotes certainly suggest that this is something that's helpful, right? We have our lowest ever observed to expected sepsis mortality, one of the lowest across a database of University of California and other academic sites. You also notice that the algorithm that we put in place, Shamim had published on how we taught it to say, I don't know. Why? Because a doctor who tells their patient, I don't know the answer to that, but I'll work with you to find out, gains more trust from the patient. And if you want these AI algorithms to gain trust, they're going to have to be transparent in terms of their confidence, right? So about 8% of cases, we find that our algorithm has insufficient data to make a prediction. And we'd rather do that than create a bunch of false alerts or create false confidence in an algorithm that shouldn't be there. Another thing that our center is doing is a lot of remote monitoring. And we started this project as what we called P1000 to put 1,000 of our primary care patients on remote monitoring. It's now P10,000, and some of the data in press shows that in our hypertensive patients with no new medications, we've seen an average drop in systolic blood pressure of 20 millimeters of mercury, diastolic by 10. In our diabetic population, average drop of A1C by about 0.5%. This is very consistent with a lot of other data that's emerging around digital therapeutics. But now we have an entire team dedicated to population health, care gaps, and remotely managing patients. And as you heard about, this is the type of thing that can change the care model, right? Perhaps your diabetic patients don't need to come in every 6 months for an in-person checkup if you're actually managing those patients with the worst A1Cs and getting better outcomes remotely and doing telehealth visits. And in fact, when we started having problems with boarders in our emergency department, we said, hey, we've got a remote monitoring team stood up already. We know that admission rates by attending physician in the ED vary from about 20 to 30%. A lot of that's correlated with years of experience. Let's give those younger attendings an opportunity to discharge the soft admissions to a remote monitoring environment with a nursing visit and a physician telehealth visit. And so that same team doing remote monitoring, our outpatient stood up the acute care home. We've now seen over 500 patients that have been remotely monitored after discharge, and it's helping with capacity in the hospital. Now, I want to wrap up by saying all of these digital projects you've heard about are really quality improvement projects, right? And so I actually think one of the most important things that I've done as the Chief Medical Officer is to stand up this committee, and I love the acronym. It's aligning and coordinating quality improvement research and evaluation. Because remember that Hastings report about sort of the blurry lines between quality improvement and clinical research, right? We're purposefully changing the paradigm at UC San Diego Health. So historically, I would get a call from the IRB director. Dr. So-and-so says he's doing a QI project, wants exemption so he can publish. What do you know about it? And my answer was always, that may be QI, I've never heard of it. And so we're flipping the script. We're encouraging our faculty and nursing leaders and others to bring their quality improvement projects to this committee where we have members of the IRB and the hospital quality team talking in the same room about whether things meet the criteria for human subjects research or not. And one thing that's commonly misperceived in the United States is that intent to publish is criteria for IRB oversight. It's not. You go to the Health and Human Services website, it's generation of new and replicatable knowledge is the criteria. So if you're doing a quality improvement project that's really intended to understand how can we optimize something in our local environment, that's IRB exempt. Now, how do we incentivize our physicians to bring this here? Two ways. One is we have that IRB exemption form letter, so if they want to publish it, they can, and that creates alignment between the School of Medicine and the health system. In fact, I've incentivized all of my medical directors, 160 of them, on doing quality improvement projects that align with our hospital goals, and then either getting Lean Six Sigma improvement certification or publishing every year. The second way that we incentivize it is that as a hospital, we can now disseminate maintenance of certification credit, which all of our physicians need to remain board certified. So that's a big kind of carrot. What is the result? Well, as of this morning, I was looking, we've got over 200 QI projects that the hospital previously never knew about, right? Because our whole goal is for our workforce to all be improvement oriented, right? Not all improvement needs to be managed by the health system. And so we now have this database and we advertise it with our trainees. Because Peter, our trainees, they all want to get involved with publishing and quality improvement so they can match to fellowships and get good jobs and things like that, right? And so now instead of having to be a matchmaker, I say, hey, go check out this database, find a project you can participate in, because I guarantee you there's some faculty member who wishes you would write up their data for them. And so we actually wrote about this in a recent paper with my Dean and Vice Chancellor, Dr. Brenner, about developing a highly reliable learning health system. Because in academic medical centers, not only should we deliver highly reliable care, right, which is a tenet of Joint Commission and quality improvement, but high reliability is really about using current methods, right, known best practices to improve. But as an academic medical center, we should be learning health systems that are also developing the new best practices, learning from our own data on a constant basis. And so our entire health system leadership is now buying into this. This is our stated mission, is to be a highly reliable learning health system. And all of our medical directors know this. And my goal is for every one of my medical directors to be partnered with a data scientist or an industry partner or a clinical informaticist, developing new and innovative ways to push the field forward. So not just using the current sepsis bundle, but we're thinking about ways that we can make sepsis a never event, right? Because ultimately, our healthcare system should be learning from every patient at every visit, every time.